Okay. One more second, and I think we are going to stream. I'm not sure if this worked or not. Hold on one second.
It says we're streaming live.
Okay, well that's good because I can't even see it on my screen. So I have no idea what's happening there, but that's okay. If it says we're streaming, I'm going to trust that we're actually streaming. But for whatever reason, now I can't see my screen. Okay, this is not what I really envision. Okay, one second, guys. Thank you for your patience this evening because there it is. This is our first attempt at this format. Okay, so we've got a couple more people who've joined us. I don't see any more speakers there. And without further ado, I am going to hand over intros in just a moment. And so I'm going to give you some housekeeping tips. And then I'm going to hand over to Dr. Gonzalez for a few minutes. I'll be presenting and then we'll go through our agenda. So we are streaming on Facebook. If you are watching this on Facebook, you cannot participate in the polls, and we will not be addressing questions posed to the Facebook page. If you would like to engage in the meeting in real time, you have a link on Facebook that you can click at any time and join the meeting. You do need to register with a name and email to come into the meeting, but you can then join us after the webinar portion of this event in a private meeting for questions and answers to specific questions. So without further ado, wait, there's one other thing I wanted to say. So you're doing the poll right now as you're coming in the room. I'm going to leave the poll open for a little while. It just gives us an idea of where people are coming to us from, where they're viewing from, and their HCM experience. So please do take that. And I will be thanking our sponsors in just a few moments. So without further ado, I'm going to give the intros over to Dr. Gonzalez. Would you like to do a screen share? Do you have any opening slides?
Yes.
Okay. I'm going to leave the poll running for a little while.
Perfect. Can you see that one? Yeah.
We can see that. Thanks.
Perfect. Excellent. So, well, thank you, Lisa, for organizing this, for having us. We're honored to be one of the first, well, actually the first center that we have tried this online, and hopefully becomes a success as we learn how to use Zoom. I learned at least to put the background. Hopefully you can see it. Since I've been teased a lot about, even from patients, that they can see my garage from my house. And my kids, room behind me with all of them like running around. I think like at least like 3 or 4 patients of mine already have met my kids just through Zoom. So so happy to have you guys here and presenting some brief talks today about hypertrophic cardiomyopathy, and we're happy to have the relationship with HCMA Center. Since around early 2019, we started the clinic approximately in 2017 and involved quite a few of us. Some of the speakers that you will be seeing today, Dr. Srivastava and I were the co-directors of the clinic, and he's a heart failure physician. I am a general cardiology with advanced imaging, primarily in CT and MRI. And Dr. Tierstein, the director and head of the chief of the division, it's an interventionalist. Along with Dr. Price, they're in charge of most of the procedure with alcohol ablation and catheterization in patients with HCM. Dr. Haywood is the head of the heart failure program, and Dr. Mohan, also member of the heart failure division, which mostly see also the core group of patients along with me with HCM, and along with all the general cardiologists in the practice, and provide mostly the advanced support in most of the mechanical circulation and heart transplant management. Dr. Smith is the head of the Echo Lab and runs mostly our non-invasive cardiology stress test area in La Jolla. And Nick Olson, it's our electrophysiologist, and also involved in pacemaker implantations. Other people involved in the program, Karina Chavez is pretty much the ACM program lead. and members of the heart failure division and also from my office staff are involved in part of the structure of the ACM program at Scripps Clinic. It's mostly located at the campuses of the in La Jolla of the Scripps Memorial Hospital, and pretty much that area is right now under construction and development with more towers and hospitals to come. But primarily it's out of the main office, the John Anderson Medical Pavilion, which is located attached to the Scripps Memorial Hospital. The patient workflow is very simple. Pretty much when the patient gets diagnosed and decides to call Scripps, we have a referral line in place. The number is 858-331-2018. And that goes through an ACM line that eventually gets to the referral primarily to the core clinical faculty or a general cardiologist, depending upon the location, geographical location where their clinics are. We have all the way to a new office now going to Oceanside, to offices all the way to Rancho San Diego, Rancho Bernardo, and Mission Valley. The core clinical faculty are the heart failure division, which Dr. Haywood, Dr. Mohan, Dr. Srivastava are part of it, and myself included. And from there, it's a multidisciplinary approach in which we refer, depending upon what needs the patient will have, to different members of the division, like Dr. Olson, Dr. Gibson, Dr. Rogers for device, electrophysiology, and pacemakers, or ICDs. Interventional cardiology, Dr. Tierney, Dr. Price. The advanced heart failure therapies to the heart failure team, and referral eventually for transplantation. If needed, they're all outside Scripps at the moment. From the CT surgery, we have involvement with 3 of the surgeons, but since we do low volumes, still we refer most of the patients, primarily all of them, to institutions outside. We have relationships locally with Rady Children's Hospital for those kids who are below the age of 18, or patients who have children and that they need someone to really work on them. We have relationships at Rady Children here in San Diego. Cedars-Sinai is primarily our referring to for transplantation outside the city of San Diego. And most of our patients so far that we have at least referred for the last 2 years since we're on ACM program are the Mayo Clinic, the Cleveland Clinic, all the way to NYU in New York and Stanford here in California. And so we're very happy to have this relationship, primarily because we also believe that, you know, we could do 5, 7, or 8 cases of ACM surgically every year. But to tell you the truth, for a surgeon to be very proactive like this, you have to do hundreds or even more, which is an example of many of the centers that are listed here. And that's pretty much. We're very happy to be part of this. We're very happy to be the first one that started the Center of Excellence here in San Diego and be recognized as the #1 in cardiology in the city. And we're happy to provide that care and continue moving forward to provide all the care for the patients with hypertrophic cardiomyopathy, not only in San Diego, but also in Southern California.
I'm gonna guess that picture was taken at the summit within 6 months of my transplant. So we really need to retake that picture because I still have transplant hair and transplant belly. So we got to get a new picture. So
I knew you were going to say something.
Yeah, Lisa didn't like that picture very much, but it's okay. I was there to have the picture taken, so that's a good thing. Okay, so thank you for that introduction to the program. That was very helpful. Anybody needing information on how to make an appointment with the center, you can always go to the HCM directory and get the information there. Okay, AJ's shown up. We have 3 of our speakers, so we're in good shape right now. We have 1 more coming in. All right, so I am going to take the podium for a moment and talk a little bit about the HCMA tour and what we're doing here. So I am going to do a screen share and we're going to start my presentation. So welcome everybody. As a note, I'm leaving the poll open, so you can take the poll for a little while, and when we get to a break between speakers, we'll take a look to see who's in the audience in terms of demographic makeup, etc. Reminder again, if you're watching on Facebook, you can join the conversation and be part of the Q&A by using the link at the top of the page to register into the webinar and come into the Zoom webinar and join us there. We will not be addressing questions from Facebook tonight. So thank you all for joining us tonight. This is the first in our HCMA Presents Bighearted Warriors Unite tour. And this has been a lot of work. This was supposed to be an in-person tour. We were supposed to visit about 11 cities this year. COVID happened, and here we are on Zoom. And you're in my house right now. So I want to go through tonight's agenda. We're going to be, you're going to be hearing from me for a little bit. Then we're going to be hearing a talk about who needs an implantable defibrillator. And we're going to then be talking about, I'm just going to cross myself over here. We're going to be talking about how to choose the right path for yourself in HCM, mimickers of HCM or phenocopies, and the role of cardiac MRI. So we're going to have some really great talks tonight, but we would not be able to do any of this if not for our sponsors. And we'd like to thank Myocardia, Cytokinetics, Boston Scientific, and Invitae for their financial support of what was supposed to be a live meeting, but has morphed into this digital format. And they've been great sports and sponsors along the way as we've had to ebb and flow and change because of COVID. Okay, so I'm going to give you a very high overview of some of the topics that we're going to hear deeper about later, but I want to explain HCMA's role in all of this. And I've somehow missed, we are missing a slide, and this is why I normally check my slides first. For those of you who are unaware of the hypertrophic cardiomyopathy model, we provide services to those who do not have HCM by raising awareness and education about hypertrophic cardiomyopathy in general, as well as when you're diagnosed with HCM. We're going to go over the programs that we have created for you and that we're developing and that we're building out as the years progress. We've been doing this since 1996. We're almost approaching our 25th anniversary, big anniversary coming up. But the first connection that most people have with HCM is the challenge to get diagnosed. And many patients with HCM suffer from a lapse of time from first symptom to diagnosis with misdiagnoses or inappropriate diagnoses of asthma, athletically induced asthma, panic attacks, anxiety attacks, depression, mitral valve prolapse, and innocent heart murmur. We're getting to learn a little bit more about how to capitalize on medical records and electronic medical record systems that we're hoping to create some algorithms so that when you see the combination of these issues on top of a family history of heart disease of any type, that maybe it will help people recognize the signs of HCM sooner. So stay tuned for more on those projects that we have going on. Now, if you have hypertrophic cardiomyopathy, you've probably been told some statistics over the years, but we're struggling with a little bit of a problem. And that problem is we thought it was 1 in 500 people had hypertrophic cardiomyopathy. There was some data out of a number of different studies that were echo-based that told us 1 in 500 echoes had HCM. But with the enhancement of imaging through MRI, which you'll hear about tonight, and genetics, which we won't be talking about tonight much, but we will talk about this in later events, it's really probably closer to the 1 in 200 number. Now, that's a little bit of a soft number. Some people say 1 in 300, some people say 1 in 250. So we're putting the question mark there. So we know that over 750 million or 750,000 or as many as 1 million people in the United States have HCM, yet only about 120,000 of them are in clinical care for HCM. So there is this huge opportunity to identify more people and get them to the right treatment pathways. So first of all, are we all talking about the same disease? There are sarcomeric mutations that look like they cause HCM. There are unknown mutations that look like they cause HCM. And then we have the non-sarcomeric metabolic storage disorders or glycogen storage disorders that can cause HCM. This is why it's really important to get to a specialist who understands HCM, both on the pediatric side and the adult side, so that we're treating the right disease. Things like Fabry's disease have their own treatment pathways. Danon disease or LAMP2 mutation, we're doing investigations in those diseases to potentially come up with new pathways of treatment. So it's really important to understand the underlying etiology of why you have hypertrophic cardiomyopathy. So if any of you participated in the patient-focused drug development meeting, which I'll be touching on briefly at the end of this talk, you may have seen this chart before. These are the basic pathways of HCM. There are side roads to this path, but this is generally the pathways that people follow. Either you're gene positive and asymptomatic, or you're clinically diagnosed and asymptomatic, and then you need follow-up for life, or you're at high risk for sudden cardiac arrest and there's ICDs and drug therapy. You have progressive heart failure symptoms and you're obstructed, so you have a pathway there. You have advanced heart failure and no obstruction, which leads you down another pathway, which is the pathway I ended up going down, or your atrial fibrillation and stroke, but you can be in multiple pathways simultaneously. These are some of the challenges that we face with HCM. Now, I'm going to talk a little bit about why the Center of Excellence program that we run is so critically important. If you to look at the average number of cardiologists in the United States and how many patients they see in their practice, you'll see that a general cardiologist tends to see about 2,000 patients in their entire practice, which means that on average, they have less than 10 patients with HCM. Now, as I spent time in the earlier slide explaining, there are multiple pathways and percentages of us end up in different buckets at different times. So if a cardiologist only sees 10 patients, the chances of them seeing more than one person, just like you, become very slim at best. So we created a number of years ago the HCMA Recognized Center of Excellence program, and Scripps is one of those programs. This is our current map, and this map is constantly evolving. I was very happy to add a little under evaluation or pending evaluation done in Hawaii and Colorado recently. So we continue to add to the program so that we can make sure that patients with HCM have excellent care as close to home as possible. We are excited to announce that we're trying to work on some international endeavors as well, but we'll talk a little bit about that later. So what is an HCMA Recognized Center of Excellence? And I just saw Dr. Gonzalez kind of say, wait a minute, how did my picture get up there? So an HCM Center of Excellence has a HCMologist at its core, and that is somebody to organize the program and help guide care. Now, while you're guiding care, we know that everybody with HCM has a lot of imaging. You've had a lot of echoes, maybe MRIs, maybe other testing. You've seen an electrophysiologist, you've been evaluated for heart failure, you may have gone through genetics or a mental health professional, because that's the way that we all end up in these little buckets. And your care goes through these little buckets, but then it comes back to your HCMologist, so that one person is coordinating your care. So that if you're having an episode of atrial fibrillation, yes, it's critically important that you have an electrophysiologist involved in your care, but it's also important that your heart muscle gets taken care of and that somebody's keeping an eye on your heart failure symptoms. And that's why it's critically important that a Center of Excellence care model is surrounded around the HCM specialist or the program director. So you're going to hear some new terminology coming up as new guidelines come out later this year. And in that, you're going to talk about comprehensive HCM care and primary HCM care and primary cardiologists. Every one of these care models has a role in HCM. Primary cardiologists are critically important. We need every HCM patient to have a cardiologist in their own community who can take care of things in an emergent basis and can do some base diagnostics, maybe some advanced imaging, maybe some additional work. But as you have seen in the previous slide, it's really complicated for patients with HCM to get comprehensive care at the local level just because of the lack of experience. So a comprehensive center is one that offers everything from pediatrics to transplant and everything in between. Primary centers are like a structure that we have here at Scripps, where they may refer out for transplant or myectomy at this time until volume allows them to grow into that. So they are all great program designs, and they have different reasons for existing at different times, and they all grow in together. What do we know about patient perspectives from these programs? We've done lots of surveys. We've talked to lots of people at different meetings like this one, but in person. But we know that patients who are treated at a Center of Excellence feel more supported than they do in a local cardiology community. And that is both physically and emotionally. They feel better physically because we're getting care that is more consistent with the guidelines and evidence-based medicine. And emotionally, they feel more understood. Outcomes from invasive procedures have lower complication rates when compared to those receiving community-based care, and there's an ability to participate in research. We also know that the outcomes for patients from surgical mortality rates are low at high volume centers. There's a higher likelihood patients will be treated with the appropriate level of care, not too much, not too little, with that perfect balance, and they're less likely to be on therapies that are inappropriate or in fact contraindicated. So I'm going to pivot from the Center of Excellence program, and we're going to talk a little bit about some social media support that we offer. You'll recognize this if you're on the Facebook page right now watching. So we have a new format. We actually are just rolling this out as we speak. One of them just got changed today. So for clarity purposes, from this point forward, any group that is an official Facebook group of the Hypertrophic Cardiomyopathy Association will have this look and feel. So this is our official page header, and our groups will have this header on top where it will tell you it's an official group, the name of the group, and that is an indication to those who are visiting there. The HCMA is moderating the page with trained moderators. We are monitoring the content. We will not allow medical records to be posted onto Facebook for privacy reasons. And there's a bunch of other considerations that we take into account, mostly that it is a kind, welcoming community that is non-judgmental, and that we allow different perspectives to be shared, but we keep things very scientifically based, so you can trust that. Now down here at the bottom, you'll see I say keep an eye out for HCMA-I. We are going to have more of these pages rolling out for different nations. So you'll see HCMA group for maybe another country, maybe, well, I don't know, maybe Sweden, or maybe Portugal, or maybe Australia, or maybe someplace else. So you'll see a lot more of these pages popping up in the next year. We are also working on rolling out our online support group tools. We trained 14 people last week on how to become an HCMA online support group leader. We are evolving that program as we go forward. They will be maximized to 25 individuals per group, so we can keep the conversation rolling and intimate, but not one-on-ones. And if it gets too big, we'll break them out and we'll do them into 2 different groups. We are creating a more formalized way of our peer-to-peer support systems. We will be training our peers, or mentor peers. It'll be survey-based matching. You'll tell us what you're looking for. We'll try to match you with somebody who can best fit your needs. You might want to talk to somebody who's already had a myectomy, or somebody who has an ICD. You'll put in a request. We'll match it with somebody in the system. It may last a phone call, or a chat session, or a text session, or it may last for much longer. So we will be training everybody coming up in the next couple of weeks. We'll start that program, and I'm going to tell you all how you can get involved with these programs later. You can participate and share your story. So this is a multimedia type environment where you can either participate in a podcast with myself, or you can share your story via a Facebook interview, or a hybrid approach like we saw in our patient-focused drug development meeting. I'll be providing a link for that shortly. So this concept of share your story, we'll share these individual stories in our new website. I'm not going to talk too much about that tonight because it's really exciting what we're planning. But you can share them on social media. It will be on the website and other media outlets as well. So you can join in on that. Oops, I just went too far ahead and I don't know where I went. Sorry about that. Didn't mean to make y'all dizzy. So we've also got a new program for our legislative action. We kicked off the Elizabeth T. McNamee Committee in the fall of 2019. And I don't know what's happening here. Something just happened to my computer, but I think that was all just me. Sorry about that. And I'm back, I'm sorry. So the Elizabeth K. McNamee Legislative Subcommittee started last year. We've got our infrastructure pretty well done. We have about a 240-page training guide. It's a state-by-state training guide that we're going to be training advocates in, primarily for the purpose of raising awareness on the state legislative level to include cardiac components into a well-child examination like we do here in the state of New Jersey. We will also support AED CPR legislation and Good Samaritan coverage for anybody providing CPR or AED services. On the federal level, we'll be supporting health insurance coverage for pre-existing conditions and supporting the FDA, CDC, and other federal agencies on matters related to clinical trials, discovery, patient safety, and related items. If you participated in, oh, there it is, our patient-focused drug development meeting, which occurred, oops, no, I don't want that. It's actually going to run it, which occurred on June 26th of this year. You can go to YouTube right now and you can watch it. It's 4 hours. I don't think you want to do that right now because you're kind of busy. But these are some of the screenshots from the patient stories that we told. And we will be using this type of a format in your Share Your Story and be using these segments in upcoming endeavors from the HCMA. So if you want to get involved with any of this, there's going to be a survey that you're going to have an opportunity to complete at the completion of this seminar. You'll get one, you get an email link as soon as it's over, and you'll get one tomorrow as well. And you can, number one, tell us what you thought about the seminar. And number two, tell us if you'd like to get more involved. Some of you may already have completed those surveys, and we are rolling out projects slowly over the next couple of weeks with our wonderful staff, which I'm going to talk about in just a moment. There we go. So I do want to take a moment to recognize all of our Center of Excellence partners, specifically Scripps, who are joining with tonight, and our staff. Amy has come on board to be our meeting planner, and she had to take a direct pivot from an in-person meeting to virtual, which was a fun thing to do. And Valerie, who works with our Center of Excellence staff as a coordinator there, they have been doing a lot of the coordination of bringing this meeting to the point where we're deploying it. And Ella and Julie from our team have been helping with the deployment and getting things organized. Julie is our volunteer coordinator. She'll be joining me later in the meeting room. You can talk to her about volunteer opportunities as well. And to the rest of our staff, we really appreciate all of their efforts to get the word out. Donna on staff, Corinne, who is one of our contractors, they've just done a phenomenal job of bringing this all together and making this program successful. And of course, we want to thank all of our board of directors, our volunteers, and of course, Brandy, my heart donor, because without her, I wouldn't be here today. So I'm going to stop sharing my screen and say thank you very much. And I'm going to pivot before we hand it back to Dr. Gonzalez. And I'm going to show you the poll. I'm going to end the poll right now, and I'm going to share the results. So the majority of you are coming from the West Coast. The majority of you are patients. The majority of you are on medication, but we've got a few of you that are diagnosed in the last 2 years, a couple with ICDs, some who have already had septal reduction therapy, a few of you in AFib, and a few of you have also lost family members to HCM, and many of you have had genetic testing. So we have a pretty good mix of those with HCM and a lot of shared experiences. So without further ado, I'm going to mute myself, and Dr. Gonzalez is going to present. You're on mute.
Oh, is May next? Perfect. Okay. So let me see if I can share here. Perfect. Okie dokie. Excellent. So can you see the screen? I hope so.
Yes, I can.
Perfect.
Thank you.
Okay. So we'll happy to start. I'm going to talk about primarily the part that I manage the most, which is the initial part, which is the diagnosis, and which hopefully for those who are not being treated at Scripps and or go to their local places, they have had a cardiac MRI, and so it provides a huge amount of information. And I'll be as brief as I can because this topic we could talk about it the whole day. Disclosures none. For hypertrophic cardiomyopathy, you already talked about that intro, but I just wanted to make sure that from, we do like a big focus message that ACM is it's the most common hereditary cardiovascular disorder along with bicuspid aortic valve. The prevalence is thought to be 1 in 500, and I agree with the data you presented. We all learned over the last 5 years that perhaps from provocative research shows that it's more common than what we thought. It's a genetic disorder primarily with autosomal dominant inheritance with variable penetrance, which is basically that it can be is primarily obtained by your parents, from your parents, but it can express at any time in your lifetime. So when people say, well, I didn't have it, would have an echo when I was 20. Well, you can get it later on when you're like 50 or 48. So it shows up at any time in our lifetime. It is more commonly seen in people who are young, and that's why the reason is one of the most common causes of sudden cardiac death in young individuals and athletes that you see, and they make most of the news. Sometimes when you see someone dropping in a World Cup or any game, most common seen in adolescents, but don't forget, which is the important part of the slide, that it can be also seen at any time, at any moment in life. And we see this very commonly. I would say more than 2/3 of our patients come because they have a misdiagnosis for a long time, thinking that it was due to hypertension or other causes at age 40 or 50 or 60. From that prevalence, I just showed you that if in the world there are 7.1 billion people and there's 14 million people, you use the mathematical 1 in 500. In the United States, 325 million people, in theory, 650,000 individuals. And in San Diego County, there's 5 million supposedly, or the 10th largest city in the United States, approximately. There will be 10,000 people. And so we know what you presented, I 100% agree with, is data that is very old, in which you can see that when we take in consideration advanced imaging with cardiac MRI, genetic testing, the prevalence has been a little bit more common than what we originally we thought and we were taught in medical school. 1 in 150 and 1 in 200, which basically, just to put it in perspective, if we change that prevalence, the numbers actually are inflated. And in reality, in the world, and from 14 million, you will go to 36 million. In the United States, for 650, you go to more than 1.5 million people. And in San Diego County alone, you'll have 25,000 people. And the part is that I don't think more, even combined with all the hospitals in San Diego, we will probably have not even more than 1,000 patients among all of us, which means there are like 20,000 plus people walking in San Diego with the diagnosis, and most likely still not even with the have been diagnosed formally by a physician. And one of the reasons is because mostly traditionally during general cardiology and doing cardiology fellowship training, where most of us, we get trained only on echocardiogram. And I love echocardiogram, but sometimes the pictures are not perfect. So this picture, for example, we encounter this very commonly. You can barely see the heart moving, as compared to the second image, in which is a little bit better, but still some of the walls in the bottom of the heart, they're not very well visible and they're shadows. There are better pictures like this one and this one, which I wish all patients had these images, but the reality is that it's not. And this has nothing to do with weight, it's just pretty much the configuration of the patient. And it's very hard to tell which patient is going to have some of these images just by looking at them from the office perspective. And making the diagnosis, if you make the diagnosis of ACM based on the image on the right lower corner, it would be very easy, but most of the time that's not what we encounter in office. Meaning the cardiac MRI is very often the one that confirms the diagnosis. And you can see how by the pictures shown here, that they're very pretty. We don't have the same problem that we have on echo if the person is very skinny with ribs, where we can put the probe, or is someone who is very obese. It doesn't matter. The pictures have nothing to do with that. And most of the time they have a good delineation of the markers of the borders. And we can tell a lot of information, not only anatomically, functionally, but also we will discuss later about prognosis on those patients. It plays a big role in the differential diagnosis in a patient like this one with enlargement of both atrial cavities and the ventricles. You can see that we can also make the diagnosis of amyloidosis or suggestion of amyloidosis based on MRI. We can also differentiate what type of hypertrophic cardiomyopathy you will have. If it's just obstructive, like Lisa says, the HOCM, or you have the apical form of ACM. And it also, in other pathologies, in which my colleagues from heart failure see very often, people also as well with non-compaction cardiomyopathy and other dilated cardiomyopathies as well. The MRI also helps a lot in terms of planning for surgery in some of the centers like Mayo Clinic and NYU and Cleveland Clinic. They have described a lot of the anatomy and the procedures themselves about how to fix patients, not only with the myomectomy and removing the septum, but also all the different configurations of the mitral valve and abnormalities in which they can do repairs to this valve. And MRI, as long with CT, helps a lot on that definition and the visualization of the valve, along with transesophageal echoes. So it also plays a role in planning for surgery and procedures. In the guidelines currently right now, the cardiac MRI is indicated as a class 1 in those patients in which the echo is inconclusive and there's additional information may have an impact on the management of the patient. This is important because I strongly believe that not many echoes, I would say, as the pictures I showed you before, mostly only like 10-15% of patients has beautiful, crisp, perfect images in which you feel confident to make the diagnosis. Not only the diagnosis, but pretty much the prognosis, which we will see has a huge impact on the patient's future in terms of indications for ICD or surgery. And it has the additional information is kind of like a wide open indication. And I think it has a lot of impact on the management on those patients, especially when patients come to a center of excellence and get a good quality MRI. We know by guidelines the major 5 risk factors, and I mentioned this to all my patients, is for establishing an ICD is family history of sudden cardiac death, and thickness that is beyond 30 millimeters. Someone who passes out and we cannot explain why. It's not because it was dehydrated, it was the hot summer in Palm Springs or in the desert. Is something that we cannot explain it. Non-sustained ventricular tachycardia, which Dr. Olson will talk a little bit further, when patients have some arrhythmias, ventricular arrhythmias on the monitors is also a risk factor. And when the patients go into a treadmill and they have a low blood pressure, almost passing out from low blood pressure because of the obstruction when they're on a treadmill running. And so despite knowing those are the risk factors and putting the patient, depending on how many of those risk factors they have, put them in perspective and finding out and deciding if they need something like an ICD to prevent sudden cardiac death, still using those classic risk factors, we still lose some patients. And unfortunately, there's some data that's shown that it's as high as 5 to 10% on those patients when they're followed longitudinally over decades. And so we're still missing, or we can improve in trying to identify those patients at risk for sudden cardiac death and improve in trying to save those lives. And so the guidelines are very clear cut in which a patient has a family history of a first degree relative who dies from sudden cardiac death, like your father or your mother, or if the patient has a wall thickness that is beyond 30 millimeters, or the patient passes out and we cannot explain it, the ICD most of the times is reasonable, but most of the time that's not what we find. In clinic, most of the time that we often find is a non-sustained ventricular tachycardia, that arrhythmia that you will see that doctors order in the Holters of patch monitors of event monitors that is always sent to you and discussed with you. And that's where some of the times we decide, depending on the age of the patient and other factors, what to do. There is cardiac MRI, the story with the gadolinium enhancement is called, which is the fibrosis of scar. The story started in the early 2000s when in the UK and the Mayo Clinic, they started noticing that people who have the fibrosis and the scar and the MRI, they had worse events. They had worse heart failure, they had worse arrhythmias, and therefore sudden cardiac death. And around 2012, abstract was published from the Warren Manning lab from Beth Israel in Boston. And they found that also as well, the similar evidence. And they found that a number of around 15% of gadolinium enhancement, when the patient had more risk for sudden cardiac death. And the theory or the hypothesis is because due to arrhythmias caused by the scar. And that was published later on in a paper in the Journal of Circulation. And they found that those patients who have that threshold, around 10 to 15%, they tend to have worse outcomes. So in every MRI that we read, most of the times, that's what we always put in the report because we're trying to give the referring doctor the idea where that patient lands in terms of risk. Unfortunately, the guidelines today, they're not up to date. There's still all this component or this idea of fibrosis, sudden cardiac death It's something that is still is on research. And that's why still in the guidelines is not a class 1 indication or something that we should consider for all patients. But to tell you the truth, in most places where they do advanced cardiac MRI and in most center of excellence that I know, there's no patient of HCM that doesn't get an MRI. Currently, right now, they already stopped the inclusion of patients for this trial, but it's a multinational trial involving multiple centers or led by my former mentor from the University of Virginia, Dr. Christopher Kramer, and Dr. Neubauer from the University of Oxford in the UK. And this will be probably, hopefully, bring all the answers that we've been waiting, if this ultimately will make an impact in guidelines, and also added as a 6th risk factor for patients potentially for sudden cardiac death conversation, and have that conversation with the patients to decide if we put an implant device or not. I think the best way to do this is to show you, to finalize our case, to show you kind of like how in my mind, I tend to use the information in the MRI to bias me clinically in terms of what I will do with a patient. This is a patient who came recently to see me, 55-year-old male with a history of HCM diagnosed a decade ago. He was seen in cardiology around 2015. He was asymptomatic and he remains asymptomatic. He was at the time, he was told he was okay, and he was told to follow up with cardiology in 3 to 5 years. He has no family history of HCM. He had no family history of sudden cardiac death, and he has never passed out in the past. In 2015, the workup here at Scripps, he had an echo that showed a very minimal LVOT gradient or obstruction of 15 millimeters of mercury, which is very mild, and normal pump function, and the wall thickness, it was below the 30 millimeter risk that I showed you before. The 24-hour Holter, the monitor that we put the patients, showed no significant arrhythmias at the time, and the cardiac MRI at the time showed that the patient indeed has HCM with diffuse late gadolinium enhancement, and that was all the report it says. When you look at the pictures of the patient, pretty much these are the images that we look at the end in the MRI, and anything that is here in white, it's actually fibrosis or a scar. This should look like a donut. And so this donut should look black, like this rim. And unfortunately, this patient has significant scar and across the heart. This is supposed to be like this, like a horseshoe, and it's also supposed to be black. All this is a scar, and as well in this case. This patient has probably approximately 40% of LV scar was the quantification. And the patient, if you go by the traditional risk factors as shown in the picture here below, he doesn't meet the guidelines for ICD implantation. And correctly, he did not get an ICD even at that time. However, there is very challenging because this person with just one risk factor, okay, or 0 risk factor, which is most of the people that we identify, they're in the gray zone of racer certification. And I took this slide from the summit in 2017 from Dr. Maron because I loved it because it tells you the stories. Most of our patients are here. If I get a second opinion from another center, this is where most of the patients will be sitting. And I think the MRI gives you a ton of information because remembering that slide that I showed you before, in which a lot of patients, they will still even don't meet the traditional criteria for implantation of ICD. And so when I do the MRI and I see a ton of scar like this, doesn't mean that I'm going to jump to the ICD right away, but I do a little bit more of a deeper investigation. You notice that the clinician 5 years ago who saw the patient only ordered a 24-hour Holter monitor. In this case, in this patient, I put a 30-day event monitor, so I will collect 30 days of rhythm. And if he were to have any of non-sustained ventricular tachycardia, we'll have to sit down and decide his long-term risk. He's still very young at 55. And also, if still there is doubt, in some patients, we implant a loop recorder to stay under his skin and be monitoring this patient long-term for at least a year or more to decide, depending upon the burden of those arrhythmias, if we should sit down and talk about the ICD. That's pretty much the way I think MRI uses the information of the scar significantly. And just to finalize, this is a very nice slide also from Dr. Maron that presented in the summit, in which they show that even patients with one risk factor, the MRI and the fibrosis and the scar would allow you to put them in your mind how much of a risk for sudden cardiac death they have depending upon that scar. If they had even one risk factor, but they have no scar, they are lower than the traditional criteria. If they have a little bit of scar, but it's less than 15% thresholds I show you, you're in a higher position. But mostly if you are one risk factor and more than 15%, definitely you are here. In this case, my patient is a 40 to 50% a scar, is probably up around here. And so his risk is a little bit more advanced. And that's why it makes you go deeper and try to find out if he is indeed more at risk for sudden cardiac death. Again, this is all still not in the guidelines. This research. The research will come up one day. HCMA trial is presented in the next few years, and hopefully we'll have an answer for this. But this is one of the biggest use of cardiac MRI, not only in diagnosis, but also in prognosis. Thanks. Okay.
Thank you very much. And as you can see, I came back on camera with some HCM swag. For those who can't read it, it says protecting my HCM warrior. This size is a little too big for me. I grabbed it before I left the office today. And all of our speakers are going to be getting masks in the mail as thank yous for participating. And for posterity, we can recall that this is all going on during COVID times because we're wearing masks. We also have the red ones. So you can get them online as well. So thank you, Dr. Gonzalez, for that wonderful presentation. I think you covered some really important points and I screwed up in order, and that's my apology. I was trying to do too many things here at once and I had my notepad and I read it wrong. And instead we were supposed to hear from Dr. Olson first. However, I think the change up actually feeds in nicely to a talk on electrophysiology.
That's why I have 50 messages from Dr. Mohan.
Oh. Like, that's not the way it was supposed to go. Lisa screwed that up. Okay. So I'm going to welcome Dr. Olson to the screen. If he wants to open camera, mic, and share screen, we can get going there. There we go. And he even got his camera working. Last night it wasn't working. So we're good there. You can use the Q&A box if you have a question. I can't guarantee we're going to actually be answering them while we go. It depends on what we have time for and where it fits in, but you can use the Q&A box. Dr. Olson, without any further ado, I hand it off to you.
Great, thanks, Lisa. All right, perfect. Can you hear me?
You're a little quiet.
I don't know how to turn the volume up. Can you?
That's
turn
a
the
little bit
volume up?
better. It was just a readjustment of your microphone.
All right, perfect.
Thank you.
Well, thanks for everybody for tuning in. And Jorge, nice introduction. Thank you again. I'm just going to spend about 15 minutes talking a little bit about certainly one of the most significant outcomes of hypertrophic cardiomyopathy and most feared, that being sudden cardiac death. Specifically, we're going to go into what is sudden cardiac death specifically, who's at risk, and certainly if anything can be done to prevent it. So to understand what sudden cardiac death is, we need to kind of talk a little bit about the electrical system in the heart. Now, this is going to be pretty basic, so I apologize for all those of you with medical backgrounds, but this is your heart as it sits in the chest. There are 4 chambers. 2 top chambers are called atria. 2 bottom chambers are called ventricles. Blood flows into the heart through the veins in your head and neck, and also from your legs into the right top chamber. That chamber squeezes, pushing blood into the bottom chamber on the right, called the right ventricle. This squeezes, pushing blood out to the lungs where it gets oxygen. Blood then comes back to the heart, to the left top chamber, known as the left atrium, and in mirrored fashion to the right, it squeezes, pushing blood into the left ventricle, and this pushes blood out into the arteries. Obviously, these chambers need to be in the correct sequence in order to push blood in the right direction. Therefore, we actually have electrical impulses that travel through the heart with every heartbeat that coordinate that contraction. This all starts up in the top right chamber, where a group of specialized heart cells called the sinus node will dictate the heart rate. The sinus node at rest emits about 60 beats per minute, 60, 70 beats per minute, or 60 electrical impulses. So about 1 per second. Each one of these electrical impulses will spread directly through the heart muscle of the top chambers, causing those two chambers to squeeze. Just like if you got an electric shock in your leg, that causes the muscle to squeeze. Similarly, electricity traveling through the heart muscle causes the heart muscle to squeeze. This electrical impulse then goes through a small channel between the top chambers and the bottom chambers known as the AV node. Once it goes through that channel, the electrical impulse spreads out in the bottom chamber, causing the bottom chambers to squeeze. So we have top chambers first, pushing blood into the bottom chambers second, causing the blood to go to the lungs and to the body. That's why if we listen to a heart, it has two sounds, top, bottom, bump, 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 bump. Now what happens in hypertrophic cardiomyopathy? Here we have a slide demonstrating the progression of that disease process. Over on the left, we have a normal heart with a small inset here showing the histology of the heart muscle cells. As hypertrophic cardiomyopathy progresses, we see an engorgement, enlargement of those heart muscle cells. And they also lose their coordination with each other, their attachments. And we call this disorganization myocyte disarray. And as that progresses even further over to the right, we see the histology showing very, very abnormal histology with abnormal appearing cardiac myocytes or cardiac heart cells. And what actually happens is some of those cells begin to die, and also the space in between the cells begins to produce fibrosis. This is also known as scar tissue. So how does that relate to the electrical, or how does that affect electrical activation? Well, what can happen is, if we take a look over here on the far right, and we see some scar formation has occurred here, there's a large amount of fibrosis. When the electrical impulse, which started at the top, remember at the sinus node, comes down to the AV node and then down into the ventricle, instead of normally activating the heart muscle in the bottom chambers, the electrical impulse gets caught in a short circuit around that scar. And when it does so, the electrical activation can increase very, very rapidly. The circuit can be very, very fast, over 200 times per minute. The heart muscle can't actually squeeze that fast. So when it starts activating 200 beats per minute, it actually just starts fibrillating, and the heart muscle doesn't squeeze at all. That results in no heart output. Obviously, without any heart output to all your organs in your brain, you pass out and you can expire unless that stops. This is what that looks like on an electrical heart tracing. Over here on the far left of the screen, we see 3 normal heartbeats. Obviously, this is time here. There's a small little deflection here. That's the top chambers beating. Remember, that's first. And the big spike is the bottom chamber. Top chamber, bottom chamber. Top chamber, bottom chamber. Top chamber, bottom chamber. And then as you can see here, a short circuit occurs where the scar or electrical impulse is going around that scar, activating the heart muscle chamber very rapidly. Each one of these deflections represents one of those. Now you can see this is very disorganized because it's going so fast. As you can imagine, this type of rhythm would not produce any heart output, and the patient would lose their blood pressure. Well, that sounds scary. So how often is hypertrophic cardiomyopathy actually implicated in sudden cardiac death? And the answer to that is it really depends on who you look at. Now, this is a study looking at about 1,400 patients in Minnesota between the 1980s and early 2000s. These were young athletes that died suddenly. And as you can see, in that population of patients, hypertrophic cardiomyopathy was by far the most common cause of sudden cardiac death. There were some other causes as well, specifically congenital anomalies in patients' coronary arteries. Those are the arteries that feed the heart muscle itself, so it has nutrients. But the classic causes that we see in older patients are much less: coronary artery disease, cardiomyopathy, which means any weakening of the heart muscle. Now, those are pretty rare in a younger population. As you look at older population of patients, this pie chart is obviously going to be much different. As we get older, these other medical problems become much more prevalent and take over as more common causes. So hypertrophic cardiomyopathy, by far the most common cause of sudden death in young athletes. Also a common cause, or I shouldn't say common cause, but not uncommon cause in older patients, but it loses its its percentage as you get older. Well, that's interesting, but what about in the individualized patients? If I have hypertrophic cardiomyopathy, what is my risk? And is there anything that I can do about it? We break down this risk assessment into kind of two groups. First, those are patients who've already had sudden cardiac death or a ventricular arrhythmia. Unfortunately, this is oftentimes how we discover patients. They have an arrest, paramedics show up, they shock the patient back to life, and they bring them into the hospital. We do a workup. We find that they have hypertrophic cardiomyopathy. Fortunately, paramedics happen to be by to save this patient's life, but that doesn't always happen. So we want to identify patients before they have these events. Now, if they do survive a sudden cardiac death event or a ventricular arrhythmia, we tend to treat them. We call that secondary prevention, meaning that they already had sudden cardiac death. Now we're trying to prevent that from occurring again. Now, a more common group is patients who haven't had sudden cardiac death yet, but they get identified and diagnosed with hypertrophic cardiomyopathy. Now, what is the risk of them dying of this patient population having sudden cardiac death? And the answer to that depends. Some of these patients are going to have very high risk and some are going to have lower risk. And we need to be able to figure out who is at high risk and who is not at high risk. So to do that, over the last decades, or a few decades, we've looked at large registries of patients that have had hypertrophic cardiomyopathy, and we look at which ones have had ventricular arrhythmias or died. And we try to tease out, hey, what clinical variables, what things did these patients have that caused them or put them in the group of patients that died or had ventricular arrhythmias? And let's look at the patients who never had an arrhythmia. What clinical risk factors do they have or don't have? So by identifying these clinical risk factors, we can help risk stratify patients as to being in high risk groups or low risk groups. Now, that being said, these risk factors, it depends on what study. There's a large number of investigations trying to identify the best risk factors to use. And every investigator happens to have their own personal opinion as well. So combining all of this information and looking at guidelines, not just from our country, but other countries and the European Union, there is some overall consensus on what the major risk factors are. And then there's some consensus on what other risk factors we could use that maybe they haven't been completely teased out, but we can at least use them in our clinical decision making. We call those risk modifiers. So first of all, these are the 5 major risk factors. Now, if you look at different guidelines, they may have some additional ones I'll touch base on in another slide. But for the most part, these 5 risk factors are certainly, there's general consensus that they put patients in a higher risk category. And what are those? Number 1, family history of HCM-related sudden cardiac death. A known family member that has had HCM and has had a ventricular arrhythmia. If their offspring has HCM as well, that puts them in a much higher risk category, especially if that sudden cardiac death occurred in age less than 40. Now, the reason for that is as patients get older, they can have sudden cardiac death associated with other conditions as well. So, but certainly someone dying under 40 in a close family relative that has HCM, high risk factor. Second, syncope that sounds like arrhythmia. Now there's definitely some subjectivity there, right? Lots of people can pass out. But if we have symptoms that are consistent with an arrhythmia, i.e. the patient was walking along, all of a sudden lost consciousness, didn't have any other clear explanation. This isn't the patient that's been a heavy weekend of drinking in Lake Havasu and passed out the next morning when they didn't drink any water overnight and it's 110 degrees. This is a patient who has no other clear indications for passing out. Now, this is especially true in younger patients as well. Third, massive LV hypertrophy. Dr. Gonzalez touched base on this slightly. Typically, this is assessed in echocardiograms, and that's because most of the studies done were using echocardiograms. We didn't have MRIs. for a large portion of these evaluations or these studies. But if the left ventricular wall is over 3 millimeters thick or 3 centimeters thick, anywhere in the LV chamber, we call that massive LV hypertrophy, and that's just a surrogate marker for more progression of that cardiomyopathy. Remember in the histology slide I showed earlier, more thickening of the heart muscle typically correlates with more a higher risk of fibrosis and scarring, which can put you at risk for arrhythmia. Fourth, LV apical aneurysm. What's that? Well, certain patients with hypertrophic cardiomyopathy can develop thickening in the heart muscle. And when the heart squeezes, it has a really hard time shooting the blood out of the heart. That puts a lot of pressure on the apex of the heart or the end of the heart. And that can actually cause some thinning of that heart muscle and scar formation. Again, remember, scar is bad. That can cause ventricular arrhythmias. So if we can identify this type of structure, LV apical aneurysm, on echocardiogram or even MRI, that additionally is a high-risk feature. Last is end-stage hypertrophic cardiomyopathy. Typically, hypertrophic cardiomyopathy is a process that results in increased heart muscle thickening and an increase in what we call ejection fraction, or at least a normal ejection fraction. That's where the heart muscle is actually squeezing normally. It's just too much of it. However, as the disease really progresses and those heart muscle cells not only become engorged and enlarged, they start being replaced with scar tissue, the heart muscle function can start going down. And certainly that is another risk or indicator that there's a lot of fibrosis present. All right, so those were major risk factors. Here's some other risk factors that I'd like to touch upon. In some guidelines, these can be used as major risk factors, but there is some ambiguity as to how well they can be applied. First of all, what Jorge mentioned is on MRI, we can actually look directly for scar in the MRI. This is called late gadolinium enhancement. Basically what that does is we shoot dye during an MRI examination and the scarred areas in the muscle tissue light up. Sometimes we can get thickening of the heart muscle and there's not a lot of scarring. And sometimes there's thickening of the heart muscle and there's not as much scarring. So it depends. We can actually look directly at the amount of scar using this MRI. And I think that this particular risk modifier is going to be much more commonly utilized in the years ahead as we get a better grasp on how to use the information for risk stratification. Another one is age at the time of diagnosis. Certainly patients that are diagnosed earlier in life, they have hypertrophic cardiomyopathy or thickening of the heart muscle and some of these other clinical factors earlier in life, they're at higher risk. Main reason why is as patients get older, there are other reasons for heart muscle thickening. Number two, they've also stood the test of time. And certainly patients, once they get over age 60, their sudden cardiac death risk is low, even in the presence of some other risk factors. So we always need to take age into consideration as well. Third, we touched base on, Jorge mentioned this briefly earlier, that is, we look to see if they have any ventricular tachycardia, right? What we're really concerned about is, are these patients going to get these prolonged arrhythmias that cause them to pass out and die? If we put them on a heart monitor and look for really short episodes, because usually what happens is these long, life-threatening arrhythmias are preceded by certain time period when we just get short little bursts of arrhythmia. So certainly we can look for those amounts, those little bits of arrhythmia on a heart monitor. Either you wear it for a week, a month, or even these loop recorders for years, and see if we develop any of these short arrhythmias. The problem with that is, as we get older, those types of arrhythmias become common. And when we start getting, if you put a heart monitor on your average 60-year-old, you're gonna see very often some short bits of arrhythmia. So it's a little hard to use that risk factor in isolation, especially in older patients. And we need to be cognizant about the fact that non-sustained VT is a very common phenomena in older patients, even without hypertrophic cardiomyopathy. Lastly, abnormal blood pressure response to exercise. If the heart muscle, or usually we see an increase in blood pressure as we exercise, but if we don't see that increase in exercise or it falls, that can be an indication of more advanced hypertrophic cardiomyopathy and higher risk. More risk factors means higher risk. There's no doubt about it. Looking at this study here, we looked at 0, 1, 2, 3, and 4 of those major risk factors. Certainly survival best in those with 0. As you start getting more and more risk factors, you can see risk starts to increase significantly. High risk individuals, we need to be cognizant of that. And in a minute, we'll talk about what we can do about that. Here's another study looking at 368 patients with 0, 1, 2, and 3 risk factors. The black bar here talks about sudden cardiac death. And we can see that in 0 and 1, we tend to have a lower risk. This is kind of that intermediate category that Jorge, these are the most common patients we see, however. And certainly 5% risk isn't something that we all want to live with, especially when it means that we could die from it. So this is a tough group right here. This is a tough group. We like to take this group and try to divvy them up into higher risk or lower risk, or stratify them a little bit further. Once you have 2 or more risk factors, I think it's very clear that we need to be very careful with these patients. This is from the European Society of Cardiology. You can actually take some of your variables and put them into a risk calculator, and it'll tell you your sudden cardiac death risk at 5 years and what the European recommendation is. As you can see here, there's some additional risk factors that I didn't even mention that were teased out in other studies. Again, risk factors can be identified, or there's varied opinion on what risk factors that we should be using in these risk calculation models. All right, lastly, what can we do about it? So if we are deemed high risk, the treatment that is recommended is something called a implantable cardiac defibrillator. And what is that? Basically what this is a life jacket. It doesn't do anything 99.9% of the time. It's a device we place under the skin. We put a series of wires that go down into the heart, and these wires will monitor the heart rhythm continuously. And if it detects the abnormal rhythm or ventricular tachycardia, there's capacitors inside this big device here. It charges up. There's a coil of metal here at the end of the lead, and it delivers a big electric shock from that coil back to the device. This is a newer device called a subcutaneous defibrillator. I'm particularly a fan of these devices in younger patients because there's less stress on these leads. There's less devices in the blood vessels that can be infected or damage heart muscle valves or tissue with time. This is called a subcutaneous defibrillator. The difference between this and the other model is that all the leads are on the outside of the chest cavity underneath the skin. Similarly to the last device, it monitors the heart rhythm continuously, and if it identifies an abnormal rhythm, it will charge up and deliver a shock through the heart muscle, saving the patient's life. What else can we do to consider reducing risk other than a defibrillator? Something that always needs to be discussed is activity restriction. Certainly we know that high intensity competitive sports does increase the risk of ventricular arrhythmias. Now, we're cardiologists, right? We want you guys to exercise. So moderate exercise has not been proven to be a high risk feature. Typically, a good recommendation is to avoid high intensity exercises. When you are exercising, you should be able to speak in full sentences during activity without straining. Medications, there are some medications that we can be used to reduce ventricular arrhythmias, especially if they're symptomatic. These should not be used as an alternative to an implantable cardiac defibrillator because they are not without fail-safe. Medications include things like beta blockers or even more potent medicines that are termed antiarrhythmic therapy. These would be things like sotalol or amiodarone. These type of medicines are actually designed specifically to suppress those short circuits and the fibrosis in the ventricle. So in summary, hypertrophic cardiomyopathy is a common cause of sudden cardiac death. Number 2, the risk of sudden death varies with the presence or absence of certain risk factors. These risk factors depend on who you ask, but there is general consensus on those risk factors in many, as noted in our previous slides. Number 3, in HOCM patients at high risk, an implantable cardiac defibrillator can be implanted to prevent sudden death. And number 4, some exercise limitations should be considered in high-risk patients to avoid ventricular arrhythmias and sudden cardiac death. Thank you.
Thank you very much. One item I did want to bring up about the risk factor calculator for the European study. There's no MRI calculation in that algorithm as of yet, and that has come under some scrutiny that we've known about it for a while, and there's kind of some hope that they will add that into their algorithm and give it an appropriate score, but we haven't seen that advance yet. So if anybody pops into the ESC risk calculator, there are some limitations there, including it does not it does not seem as effective for very young people as well. I think it's only meant for over 18. So it doesn't have a PEDS algorithm in there. It's an adult algorithm. Before we get on to the next talk and back onto schedule, because I'm not going to keep messing this up. Wait a second. Are we messing this up again? Who's next? Mohan, are you next? You're muted. Before you start, I wanted to bring something up that I meant to talk about after Dr. Gonzalez spoke. And that is, we talked about Chris Kramer and the HCMR study. And I think it's really important to mention that within the last 2 weeks, there was a major advance made with that particular study. And that is a $1 million gift grant from Cytokinetics to help support the next 4 years of that study. It was originally an NIH funded study. We needed to have some more questions answered, but it ran out of funding, and Cytokinetics has provided that funding. At the next break, I will tell you something really cool about myocardia. So we'll keep it peppered with information. So we're going to now talk about mimicking hypertrophic cardiomyopathy, and Rajiv Mohan is going to talk to us about this complicated issue that can really determine treatment pathways for patients. And I'm going to go back on mute. All yours.
All right. Thanks, Lisa. You guys can hear me okay? All right, great. Thanks, Lisa, for putting this together. Thanks, Jorge, for directing our program in conjunction with Dr. Srivastava. It's been a real asset to our program to be able to help these patients here locally. You know, one of the things that comes up, as Lisa mentioned in her talk earlier, is that, you know, often there's a delay in diagnosis of hypertrophic cardiomyopathy, or there's a misdiagnosis that can be made. And sometimes patients come see us down the line. They've been symptomatic for quite some time. And, you know, it takes a deeper dive sometimes into patient symptoms and their clinical findings to make the diagnosis. So, we'll very briefly review some of the more common things that we see misdiagnosed instead of hypertrophic cardiomyopathy, and we'll kind of focus on where we as cardiologists and clinicians generally need to kind of pay more attention and ensure that we're focusing our time and efforts. So part of the reason that it's so hard to make the diagnosis at times is that the symptoms are often mistaken for other issues. So patients can experience shortness of breath. As you guys all know, that poll was very helpful actually in the beginning, Lisa, just to get a sense of kind of what the audience is, what their experience is. So shortness of breath, of course, fatigue, chest pain or angina, palpitations, lightheadedness, dizziness, and even passing out. So of course, if a patient came to us with one or two of these symptoms, we may not be thinking about HCM right off the bat, but that's part of the problem, particularly with younger patients who may present with these kinds of things. They may be sort of passed on as having non-cardiac issues instead of kind of delving a little bit deeper into what might be causing the problem. And like I said, often doctors aren't really thinking of HCM kind of right off the bat because, of course, there are many other things that could cause all of these symptoms. So the symptoms, of course, can sometimes lead to inappropriate diagnoses, things like anxiety or panic attacks in younger people. So this really highlights the importance of us as physicians to do a really thorough history, because that's really where the diagnosis is going to be kind of cemented. The foundation of the diagnosis is really in the history, and is sort of confirmed with the imaging studies that we have. So it's really doing a very thorough history. If somebody has a history of syncope, passing out, what were the circumstances surrounding that? Was it just dehydration in Palm Springs, like Jorge mentioned earlier, or was it unprovoked? Was somebody just sort of standing there and went down? Those are two completely different clinical scenarios, particularly in a younger person, that would warrant completely different diagnostic algorithms. And it's not just the patient's history or their symptomatology, what they're coming with, but a very detailed family history is also, of course, very important, as we know the the genetic component of this disease. So are there unexplained sudden deaths in the family, even multiple generations and multiple, kind of relations removed? Or even in primary relations or family members, is there a history of arrhythmia? Is there a history of sudden cardiac death, passing out? Or if there's an actual history or diagnosis of HCM made, then of course it makes it a little bit easier. But really taking the time to kind of focus on the family history as well really helps. So that's kind of part of our approach as a team. Of course, the patients are being asked the same questions over and over again by all of our members of the team, but making sure that we drill down. If one of us missed something, somebody else might pick up another clue in terms of family history and that kind of thing. The other reason that it's so hard to make the diagnosis often is that the echocardiogram can, quote unquote, mimic other diseases. So of course, as you all know, and as Dr. Gonzalez-Torres has kind of described, one of the key echo features is, of course, left ventricular hypertrophy, or thickness of the heart muscle. And it's not always so obvious, as one of the examples that Jorge put up earlier. It's not always so clear where you have hypertrophy or thickness of the heart muscle all the way around. It can be in different portions of the heart. It doesn't necessarily have to involve the entire heart. Often with an echo, there are portions of the heart that we can't see as well, which may be hypertrophic, but we don't know. But more commonly, we see left ventricular hypertrophy, and it's attributed to some other problem going on, some other more common problem going on, at least more common in the physician's experience. And so the diagnostic algorithm goes a different route. But again, the patient's symptoms in combination with their family history, in combination with these left echo features, particularly left ventricular hypertrophy, all that has to be kind of put together in a way to make sure that we're kind of going down the right path. So here's an example of a patient I saw some time back, maybe about a year and a half ago, 2 years ago. It's a 68-year-old woman who presented to clinic for an evaluation, a cardiac evaluation, before being considered for liver transplant. So she's had a history of hypertension for some period of time. She's 68 years old, but she told me that she'd had a murmur her entire life, but had never actually seen a cardiologist before. And the reason that she even got the echocardiogram was part of her workup for liver transplant. It really had nothing to do with anyone kind of diving into her symptoms. But when we did dive into her symptoms a little bit more, she definitely had some symptoms of HCM, or heart failure generally, which was progressive shortness of breath, fatigue. There were times where she was having some swelling in her legs. Of course, that's complicated because the liver disease can cause some of the swelling as well. But at some point in time, as part of her hypertension evaluation, one of her primary care doctors some years ago had ordered an echo and had made the diagnosis, or at least it was commented that she had some left ventricular hypertrophy. So we repeated an echo when we saw her in clinic, and you can see this echo here on the right. This is one of those that Jorge mentioned is a little bit easier to kind of see, right? The walls are thick, but all the walls are thick, at least the ones that we can see in this view. So this kind of very much increased our suspicion that there was something else going on besides just hypertension causing this, just because of the degree of thickness. And not only was there thickness, there was a gradient. There was a pretty significant gradient that she had, I believe, her gradient. And that echo is about 70 millimeters of rest, 70 millimeters of mercury at rest. And so thankfully she had never passed out. She hadn't had those type of symptoms, but given the constellation of her history or symptoms that she had and the echo findings that we had here, I ordered a cardiac MRI, and this confirmed that there in fact was HCM. There was hypertrophic findings throughout the myocardium, in fact. And so she kind of went through the sort of the clinical pathway that we've set up, where she started at heart failure, but she ended up seeing Jorge to review the cardiac MRI, the electrophysiology team to review her risk for sudden cardiac death and determine whether or not she needed a defibrillator. In this case, she didn't really quite meet criteria for defibrillator placement, so she didn't. Thankfully for her, with just medicines alone, her gradients improved and her symptoms improved quite significantly. Ultimately, she didn't want to pursue liver transplant. Part of it was that she was actually just feeling better from a cardiovascular standpoint, and decided to hold off on that for the time being. Her liver function was reasonably stable. But thankfully we were able to treat her and get her to a point where she was feeling much better. So what are some of the other common misdiagnoses that we see for patients? Hypertensive heart disease, probably one of the most common things that we see. So patients can, of course, have left ventricular hypertrophy as a result of long-standing hypertension. But this typically needs to be significantly elevated blood pressures for a pretty long period of time. Again, going back to our history of the patient, if they've had any of those red flag signs or symptoms, then we can't just sort of blame the hypertension for the HCM, for the left ventricular hypertrophy. We need to kind of dive in a little bit more. Athlete's heart, another thing that we see on occasion, and sometimes patients are labeled as athlete's heart. Of course, this can also cause some degree of left ventricular hypertrophy. It can also cause a little bit of left ventricular dilation. There are several features that can distinguish it from HCM. Again, history being one of the key features. So if somebody's had the red flag signs or symptoms of HCM, then of course it kind of takes us down a little bit different pathway. If someone is, the tricky part with athlete's heart is that many of our HCM patients are athletes too. So it's hard to necessarily tease that out alone as a differentiating factor, whether or not they're, what level of athletic competition they're in, because many of our HCM patients are also very competitive as well. EKG changes are more commonly seen in HCM, the kind of stereotypic EKG changes that we see with the big QRSs, the repolarization abnormalities, that kind of thing. Other chamber abnormalities are seen more commonly in HCM, so atrial dilatation, those kinds of things. And one of the key features that we see, we hear about, we read about, particularly in athlete's heart, is that if an elite level athlete develops some form of cardiomyopathy that's thought to be related to the high intensity training, if they back off of that training, their heart can revert back to a more normal looking echo, which of course is not true for HCM. There's no way to necessarily revert that. The echoes are, once they're abnormal, unless of course there's some procedure done, the echoes are going to be progressive. They're certainly not going to revert backwards to a normal echo. So another kind of distinguishing feature. Another common misdiagnosis, and this one actually is interesting. It kind of works both ways. We see patients on occasion that are diagnosed with HCM actually, who turn out under further review, further investigation actually, and have cardiac amyloidosis. And then at times we see, the features of cardiac amyloidosis making the diagnosis of HCM a little bit more complicated. So what is cardiac amyloidosis? This is a disorder where an abnormal protein deposits into the heart and causes what appears to be muscle thickness, but it's really not true muscle thickness. It's actually these proteins that are kind of depositing within the myocardium, the heart muscle, that makes the heart look thick on an echo, but it's actually not muscle. It's this other type of protein. There's kind of two main types of of amyloidosis that affect the heart. The two main proteins. One of them is called TTR. It stands for transthyretin. The other one is called AL, and that stands for amyloid beta light chains. And you can see here on this left box, this is a TTR protein. It normally is produced by the liver. It has a whole bunch of different functions in the body. But for some people, for one reason or another, these individual pieces of the protein dissociate into individual monomers, and then they kind of form these fibers. These fibers then go and deposit into the heart muscle and then cause it to get thick, dysfunctional, causes diastolic dysfunction, stiffness of the heart. So some of the clinical features are actually somewhat similar in that sense, in terms of how a patient may present with shortness of breath, fatigue, swelling, those kinds, and atrial arrhythmias, atrial fibrillation, those kinds of things are common actually. AL amyloid, the other common type of protein that we see depositing into the heart, is an abnormality of the bone marrow. So these plasma cells, which are antibody factories, are involved in the immune system to help fight off infections. For some reason, one reason or another, these plasma cells, this particular clone of plasma cells, start spitting out tons and tons of proteins, antibodies of one type that are abnormal. They're light chains of those proteins. And the same thing happens. Those light chains can go and form fibrils that then go and deposit into various organs. Heart being one of the more common ones, but it can be deposited anywhere, into the gut, into the nerves, that kind of thing. But the echo manifestations of it, the clinical heart manifestations of it, meaning the shortness of breath and heart failure type symptoms, are somewhat similar. And sometimes it's a little bit hard just by history alone to make the diagnosis. And that's why, of course, to dive into the family history a little bit more, and then the imaging. So here's an example of a patient with cardiac amyloidosis. So, At first glance, just kind of looking at that echo without knowing much about the patient, you may say, oh, that actually looks like hypertrophic cardiomyopathy. The patient's heart's quite thick, it's bright. It has kind of restrictive features with this dilation of both of the top chambers of the heart, the atria. So, if you're just looking at that, you may think, okay, is this amyloid? Is this HCM? We don't really know. So it requires a little bit more imaging, cardiac MRI, that kind of thing to help tease out the difference between the amyloid and the HCM. Aortic stenosis, while it's not exactly a mimicker or misdiagnosis, sometimes this can occur in conjunction with hypertrophic cardiomyopathy. What this is a narrowing of the heart valve between the heart here and the aorta here, which is the main vessel that comes out of the heart. There's a valve there called the aortic valve. And over time, in certain conditions, some congenital conditions, the valve can become abnormal, can become tight, or it doesn't open up properly. So the tricky part is when that valve becomes stenosed and not opening as well, the heart has to pump harder and harder to get blood through a diseased valve. And as the heart pumps harder and harder over a long period of time, it starts to get thick with more muscle. So it actually develops left ventricular hypertrophy as a response to the aortic stenosis being present. So this is a little tricky. How do we differentiate aortic stenosis versus HCM? Because, we, of course, historically see the septum being thick here in HCM patients, but of course, as we know, any part of the heart or all of the heart can be thick in HCM. But if we see septal hypertrophy here in a patient with aortic stenosis, it's difficult to sometimes know exactly where that gradient is. Is it gradient in the heart? Is it gradient at the level of the valve, below the valve, or is it at the valve itself? Sometimes patients can have a combination of both. We recently had a patient in the hospital who actually had aortic stenosis and some degree of HCM. And it was clear that the aortic stenosis was present just because of how much calcium was present on the valve. But then if you look back at the echoes, you can, this is why it takes a little bit of a deeper dive. If you look back at the echoes on this patient who'd been followed by one of our partner organizations for some time, the aortic stenosis wasn't as bad 5 or 6 years ago, 10 years ago, but the LVH was already present. So that was kind of a clue that there probably was some degree of hypertrophy even before the aortic stenosis got worse. So maybe this patient probably likely had HCM before they had aortic stenosis and now was sick. So it makes it a little bit tricky about not only making the diagnosis, but then treating that patient is also complicated as well. Some other phenocopies, like Lisa mentioned earlier, these are more pediatric disorders that can come up, not really in our field because we don't really see pediatric patients necessarily, children. So glycogen storage disorders, lysosomal storage disorders like Danon disease and other inborn errors of metabolism. These are also diseases that can cause sort of a phenotype or an expression, the way things look. Can be similar to HCM, but a completely different process for each of these different kinds of things. Of course, there's multiple different disorders in each of those categories, aside from the Danon disease. So key features, things that we want to make sure we are always looking for in our patients, syncope or passing out for sure needs to be evaluated further, particularly in younger patients, particularly in those who have a strong family history, or if this is a recurrent thing that's happening. Those patients need further workup, starting with an echocardiogram and then moving on to advanced imaging like an MRI. Arrhythmias, documented arrhythmias, particularly ventricular arrhythmias, but even atrial arrhythmias in younger patients with any amount of abnormality on the echo. If it looks like it could be HCM, then that's something that we want to dive into a little bit further. Something that we see in our heart failure clinic quite frequently, heart failure with preserved ejection fractions, another diagnosis. It's sort of a bucket diagnosis for a whole host of different disorders and things that can go wrong with the heart. But what we're realizing is that maybe there may be more patients in this sort of bucket of patients that we treat as heart failure with preserved ejection fraction, meaning normal heart function or hypernormal heart function, that may actually have HCM. So if they have features of it, we need to take a deeper dive. Other symptoms like chest pain, angina, with those echo features of left ventricular hypertrophy, those kinds of things. So we keep a pretty low threshold to consider cardiac MRI and consider involving them in our clinical team to, number one, make sure that the diagnosis is appropriate. Number two, make sure that they're getting the treatment that they're supposed to have. So in your poll earlier, Lisa, you had shown one of the questions was whether or not patients that had a septal ablation or surgical myectomy. And so I just wanted to put this up there. This is actually my experience from about 1.5 years ago for a congenital heart condition that I found out about just about 6 months before I had surgery, just about 2 years ago. Not HCM, but congenital heart disease, an abnormal connection in the heart with a big hole in the top chambers. And so this was something that just sort of came up out of the blue. I had no idea. In fact, since I think you came out here, Lisa, to San Diego, so I had open heart surgery too. Went through it. So
Scars?
yeah. So it can commiserate with those participants here, those attendees who have already had surgical intervention, or can lend a hand of comfort to those patients who are considering it or may need it in the future, whether it's a heart transplant or a myectomy. That open heart surgery is a big deal, but it takes some recovery for sure. But once you're recovered, you may feel even better than you did. The whole point is to feel even better than you did before you went into it. So thanks.
Wow. Well, I wasn't expecting that. I'm looking at this picture. I'm like, wow, that guy looks like him. So, wow, thanks for sharing that. That does give you a different perspective on things these days, doesn't it?
Absolutely. Absolutely.
Yeah. So when you think that somebody needs surgery, does it come off your tongue a little bit differently now?
Definitely. Before that, it was easy to say, hey, look, this is what you need. We see patients with it all the time. You'll be in the hospital for a little while, whatever it is. But, now going through it, it's obviously a lot easier to kind of go through the details and say, okay, this is kind of what to expect. There are going to be tough times, even in the hospital, after the hospital, all that kind of stuff. So, and then, sometimes just not that, there's a little bit of a deeper consideration that goes to make sure that the time is right for when the patient needs to go to surgery, right? Not too soon, of course, not too late, but making sure that they get there when they need to, for sure.
I think you bring up a very good point, and there are a number of physicians within the HCMA network that either A, have HCM themselves, B, have a family member who has it, or C, has their own issue that's unrelated but similar. Some have devices, some have had open heart surgery for other things. And sometimes we, the patients, forget that you doctors can be patients too.
Right.
So you can come to a support group meeting anytime you want.
Absolutely. That sounds good.
You are welcome. Okay, so thank you so much. I'm gonna segue from your talk, and we'll get AJ to share his slides here, but I'm going to give a little bit of time to another one of our sponsors. We talked about Cytokinetics gift to the HCMR registry earlier. And now I want to talk about what happened last weekend at ESC. The Explore HCM Efficacy and Safety in Mavacamten in Adults in Obstructive HCM was presented. And you can see an interview I did earlier this week with Dr. Jacopo Allevato from Italy, where he talks about the study results. I will give you the very brief explanation that it was a very positive study. The drug is looking like it's hitting all the targets that they were hoping for. So the good news is we may actually have a drug, particularly for hypertrophic cardiomyopathy, in the near future. So thank you to everybody that participated in the clinical trial. Thank you to everybody who helped build the clinical trials and recruit to the clinical trials and participate in the data collection for the clinical trials. It's looking like it's all working out quite nicely for us. Okay, so without further ado, we're going to get to our last talk. And AJ, I always mutilate your last name, Stravasia. Close. You're on mute. So it's right for me for now.
Perfect. You got it.
I did. Okay, well, you can say it the right way also. So we're going to talk about medications and procedures and finding the right pathway. So I'm going to go back on mute and hide myself. And don't tell me you had open heart surgery too, right? We're not going to get another surprise. Okay, good. All right, I'm going to go back off camera and I leave them in your capable hands.
Thank you so much, Lisa. Thank you so much, Jorge, for really, and the team at HCMA. I mean, look at these threads, email threads about coordinating, just getting a group of physicians not on call the same time, and then, all the logistics that goes in behind putting this together, reaching out to patients in the community, sponsors. it really, and everything seems it's doable, it's easy, but when you actually start doing it, organizing events like this, especially around these times, so really hats off to all of you guys for doing this, and I hope everyone can take a little some home from these talks and finds it useful. So my talk pertains more along the lines of, so you're a patient with hypertrophic cardiomyopathy, and where do we go from here? We hear about medications a little bit. There are some procedures out there, devices, heart transplant, and how do we sort of navigate this and figure out who needs what? As both Lisa and Dr. Mohan mentioned, we do our very best in not trying to have someone's chest open unless it is that time and it's absolutely the right thing to do. We do everything we can with medication that sort of, rather not put a device in unless you absolutely need it, rather not have a surgical procedure unless you absolutely need it. So yes, there are all these options, but a crucial aspect of this is the timing and making sure it's the right thing for you. And A, it's going to help you live longer. B, it's going to improve your quality of life. And C, that's really what you and your family desire and want from life. I think Dr. Mohan mentioned this. The symptomatology of hypertrophic cardiomyopathy can vary a fair bit. It can be very non-specific. Oh, I have some breathing trouble, and it can take a while before a diagnosis really happens. People may say, oh, I'm a few years older. Might have some asthma. Maybe I'm deconditioned. So it can just be as non-specific as that. I'm a little short of breath. I have a little fatigue, tiredness. Maybe I'm having some, some patients with exertion will have some chest pain. You get a stress test, an angiogram, does not show any blockages, and then nothing further might happen until your symptoms get much worse. So the symptom complex can vary a fair bit. To add to some of the earlier talks, hypertrophic cardiomyopathy, it can happen at any age. Oftentimes people think it's a disease just in childhood or in teenage years. Oftentimes, yes, it's diagnosed in puberty, but it can also be diagnosed in your 30s, 40s, 50s, 60s, 70s as well. Especially now with our imaging techniques a lot better and the tools we have today compared to 20 years back, we do find patients missed with hypertrophic cardiomyopathy diagnosed later in life. Any age, any sex, any ethnicity, and there may not be a family history as well. Not everyone has this family history of, there was somebody in my family who had it, diagnosed, had arrhythmia. You may get that history, but oftentimes you may or may not have that history. So the first question comes about is, you have some symptoms or you're suspicious or someone might have said at some point, I may have hypertrophic cardiomyopathy. And as Lisa alluded to, most physicians don't see in the general practice, see a lot more high blood pressure, diabetes, high cholesterol, and a very small number in the larger thousands of patients will have hypertrophic cardiomyopathy. But for each given patient, it doesn't matter if there are 10,000 other patients with high blood pressure. If you have hypertrophic cardiomyopathy, you have it. But oftentimes in the large crowd, you can get lost. So a crucial aspect, if there's some family history, suspicion, you want to get evaluated for it, you want to find the right program, or hospital, clinic, doctor who can do that thorough evaluation. A lot of it, X amount, is pattern recognition, practice, interest, and having the bandwidth and expertise for all these surrounding subspecialties related to hypertrophic cardiomyopathy, the right imaging tools, the right heart failure specialists who will dig into your case further, do a thorough eval, and let you know if you have it or you don't have it. And the HCMA website is spectacular. If you haven't been, I recommend taking a look at the website. For someone like me who's even not a patient with HCM, it has great resources that are useful that you can share with your patients and or your families. I have shared this with my patients as well. But they do have, I think Lisa pointed this out, what we call as HCM centers of excellence, where they've already gone through this thorough vetting process and said, okay, these centers definitely have the tools needed, and there are certain centers in evaluation. And even if you're not sure if that center is not close to you, you can call the nearest center and get some guidance or recommendations on what a good center or program near you would be. So it's a useful resource. What does this diagnostic workup look like? It starts with a detailed history, a family history, a family tree. There are blood tests that can be done, genetic testing, roles increasing, and a lot more easily available, as simple as mailing a saliva test kit to your home. You just take a swab, put it in a test tube, send it back by mail, and you don't even have to leave home to do this test. EKGs, echocardiograms, the role of cardiac MRI really has taken off in the last, I'd say, 5 to 10 years in getting it from research into clinical practice. And there's a lot more data emerging, how much more useful the MRI can be in not just hypertrophic cardiomyopathy, but also conditions that are very similar to hypertrophic cardiomyopathy when you look at an echocardiogram. So it really helps differentiate. And as Dr. Mohan showed, one key aspect of our evaluation process is making sure you don't have something that looks like HCM or is just high blood pressure, really digging in deep and making sure you don't have any one of those conditions. So types of hypertrophic cardiomyopathy, we've talked fairly in detail about aspects of it. Fundamentally, it's a genetic disorder. We've not identified all the genes that are responsible for this muscle condition. So if you get a genetic test done and it comes back negative, that does not absolutely rule out hypertrophic cardiomyopathy. So that's something some patients bring up a lot. My genetic test was negative, but I have this extensive family history. Everything else fits with hypertrophic cardiomyopathy. So it means that, we've found a good number of genes, but not all the genes. Fundamentally, what the main problem, the heart muscle is really thick. We want to make sure it's not high blood pressure. It's not because you have a lot more blood flow and over time the heart muscle thickness has increased or a valve condition. We go through that process by all the tests I showed in the last slide in figuring out, is this hypertrophic cardiomyopathy or not? So once we do that, then, we lay out a family tree, because we want to confirm the diagnosis in you as a patient, but also, in potential family members who may have the condition not diagnosed with it. So we go through a screening process and, getting a detailed history. At the very minimum, usually an EKG and echocardiogram based on how this family tree falls in line. And the echocardiogram can vary, people, not always you get this very thick left ventricle muscle to start with. So that's why sort of being engaged with a program or a clinic that can track this over time, especially in the younger age, 10 years, 12 years, 15 years, the muscle can still grow as the rest of the body grows. And then you may see these changes that you can track over time. So you want to be with a clinician who's going to follow and not a one-time visit and loss to follow up when screening. So once we've confirmed it's hypertrophic cardiomyopathy, then our job is we want to lay out this roadmap. Where do we go from here? It always starts with the patient's symptoms, and that always drives the urgency for testing and also for any of these procedures. If a patient has absolutely no symptoms at rest or with moderate exertion, then okay, we don't have to rush to say you need a heart transplant, but should we see any red flags in our workup, be it on the history, be it arrhythmia, be it I just really have no energy, or the pressures in the heart muscle. If we see any clues in any one of those, then we're going to say, okay, you need to move on to the next step. The number one, I stress, I think Lisa alluded to this as well, really it's finding a good, caring, compassionate physician and a clinical team. To me, that's 1, 2, and 3, because that is really, I think, half the job. You don't, somebody sees you once and says, okay, this is fine, I'll see you in a year. or you don't have hypertrophic cardiomyopathy after just seeing you one time, I would really question that approach. And I truly believe that, especially if you have a diagnosis confirmed with hypertrophic cardiomyopathy, you want to be part of a program or a team. This is not, you're not alone. You're going to be with us. We're going to get you through whatever is needed to help you achieve your goals, living a good life. So, and just like Jorge mentioned in his slide, even if, for example, at Scripps, at this point, we don't do heart transplant, but we are your doctors, we are your team. We will make sure, if that's what's needed for you, it's not available at our program, we will do all the work needed, connect you to the program that will give the best outcomes, and talk to those physicians, get you there, make sure you have that, if they're in agreement, get you through that procedure, and we follow you right after. You come back to us. Recently, I had a patient who had a really thick heart muscle condition, and I talked to the surgeons at Cleveland Clinic because we don't have a really experienced surgeon on the West Coast to do these procedures. So I sent the records over. When they agreed, patient went the day before to Cleveland, had the procedure done, stayed there for a week, got discharged from the hospital 3-4 days, was in Cleveland for a week, and then came back to San Diego. And I follow him, and he's like a new person. I just see him once in 6 months, once in 8 months, and he's doing fantastically well. So that's why it's always key to be part of a program or a team that can make sure all bases are covered. And then once you're diagnosed, the website, the internet offers fantastic resources that allow you to learn more about the condition. Example, the HCMA website is a great place for resources. But also, if you know any friends or family who have the condition, or as Dr. Mohan mentioned, even if it's not hypertrophic cardiomyopathy, sort of a congenital condition or familial condition that runs in the family, it's good to talk to them. So it sort of helps from an anxiety perspective, and also sort of lays out, hey, this is not a death sentence. Oh yeah, I have this condition, life is over. But clearly, people do really well, and we'll find you the right team. So, and then lastly, as I mentioned, the HCMA website is a great resource. So when it comes to the roadmap, so we start with the patient. The first is the assessment. The assessment includes history, the imaging testing that Dr. Gonzalez mentioned, genetic testing as needed, and then we come up, okay, where does this patient stand from our assessment viewpoint? How symptomatic are they? Did we see anything on the MRI? Did we see anything on the EKG or monitoring for arrhythmias or risk for bad arrhythmias, like needing a defibrillator? So we do a very thorough assessment there. We also do like what we call as a functional test, meaning, yes, you have some good days, you have some bad days, but I'd like to get you on a treadmill or on a bike and get more objective data to say, okay, where do you stand today? When I see you back in a year, I will compare this treadmill test or this bike test to a test from 1 year from now or 2 years from now when you have more symptoms. And if I see a trend heading in the wrong direction, then we see what those numbers are and say, okay, now is the time. We got to move towards therapies like heart transplantation. There are therapies like heart muscle resection. So we do that objective testing to compare year to year, or even it does not have to be surgical procedures. Even if we get you on medications, we'll look at this data before medications, after medications. Do we need to customize, tailor the medications a little bit? Do we need to switch the medication regimen? That comes up. So the next is medications. Okay, do we have you on the right medications? And this, I think most commonly we see in clinical practice, patients refer to us or for a second opinion, or the general cardiologist say that I have a patient with hypertrophic cardiomyopathy. Can you take a look and make sure they're on the right regimen? So then we go through these list of medications they're on, and I'll touch upon it in the next couple of slides, what these medications are to make sure patient is as well medically optimized as possible. And then, as Dr. Olson mentioned about the devices, and if we see bad arrhythmia, you need a defibrillator. What is the right type of defibrillator? Or if you're at high risk for arrhythmias and you need an ICD or a defibrillator, helping you navigate that is where electrophysiology helps us. And then other procedures, meaning muzzle resection, heart transplantation, and something called alcohol septal ablation, which is not a surgical procedure. It's similar to an angiogram where patients get a stent. They go in, and at this time, they inject some alcohol into the muzzle to shrink the heart muscle a bit, so there's more room for blood to fill. So there are a host of options, and I should say it's amazing what we have today to offer to patients like you that we did not have 5, 10, 15 years ago. And this field is still moving at a rapid pace. And I think in the next 5 years, we're going to have a lot more approved therapies from drugs and devices in trials right now. So once we've established, the hypertrophic cardiomyopathy, I'm trying to lay out a roadmap. We've confirmed the diagnosis either with echo plus MRI, genetic testing. Then the first question we want to know, we broadly divide patients with hypertrophic cardiomyopathy into something called, is there a gradient or not on the echocardiogram? If there's a gradient, we call that obstructive hypertrophic cardiomyopathy, meaning the heart muscle is so thick near the outflow that blood is not getting out freely. So we call that obstructive. The non-obstructive, yes, there is hypertrophic cardiomyopathy, but it's a different type of a pattern. The muscle is thick, maybe all around, but there's no problems with blood getting out. So this has to be approached a touch bit different than the obstructive hypertrophic cardiomyopathy. And with the obstructive, the main goals are we want to decrease the heart rate, slow your heart rate down. If we can, slow the force of contraction and make sure you're not dehydrated so there's enough blood and volume in your heart muscle. All of that helps you get the most bang for the buck with this condition and those pressures. So that's our first step. What medicines do we commonly use? So we want to slow the heart rate down. We use beta blockers or calcium channel blockers. We want to slow the force of contraction, how vigorous the heart muscle is. We want to slow the rate of force of contraction a little bit. The right amount of water pills. Some patients can get dehydrated. Some patients, because the heart muscle is stiff, can build up too much fluid. Too little, not good. Too much, not good. We want you in the middle. And then if you have arrhythmias in the upper chamber of the heart muscle, known as atrial fibrillation, you're at risk for stroke, and we want to make sure you're on blood thinners. That's generally been the medication regimen thus far for the last few years. But fortunately, we have something new. We have a new drug that has been in trial for the last few years, and there's new data that just came out this week or last week at the European Society of Cardiology meeting, and was just published in the Lancet, a well-recognized medical journal, about a new drug, a new class of drugs, not beta blockers, not calcium channel blockers. This drug specifically acts on one of the muscle filaments called a myosin. I mean, there is actin, there is myosin. These filaments are responsible for the strength of the heart muscle contraction. This drug acts on that filament and reversibly inhibits it, so the strength of the contraction is not that strong. And this was a really well-conducted study. Multiple centers across the globe, and they enrolled. They enrolled about 250 some patients in each arm, total of about 400 some patients, almost 500 patients, and they looked at compared to just a placebo, what did this drug do? So patients got this drug, they were followed. They had a trial protocol, and at least for 30 weeks or so, they got the drug. And then they looked at outcomes. I know this is a busy slide, but very quickly, the graph on the top left, all the blue lines is this drug called mavacamten, and red line is placebo. So the blue line, that first graph, what I had told you about the obstructive hypertrophic cardiomyopathy, where the pressures are high, and you can see over 30 weeks how the pressures nicely came down with the blue line. The next curve is looking at the same pressures, but the top one was with exercise, and this one is at rest. So both when you're resting, not acting, not doing work, as well as with exercise, both irrespective, the pressures came down very nicely. The next graph below that, the third graph on the left, is a marker called BNP, a marker of heart muscle stress. And you can see even that came down very nicely. Then the heart function remained quite good. The normal heart squeeze is 50 to 60%. In this condition, the heart muscle, because it's so vigorous, can come out 70, 80%. So in this case, we don't want a higher number. We'd like a slightly lower number, which this drug achieved. The next graph was, again, one of those pressure markers, and even that trended in the right direction. The last graph on the right is basically looking at a marker of damage to the heart cells. Lower the number, the better, and even that number was achieved. All in all, this drug achieved every endpoint expected or tested across the board with no significant side effects compared to the placebo, and was really well tolerated. So this is sort of groundbreaking in the field of hypertrophic cardiomyopathy, having this drug do so nicely. I think this is going to change the care of hypertrophic cardiomyopathy. It's fantastic for patients. Now the next group, so this is all in the obstructive group where those pressures are really high. The drug is also being tested in the non-obstructive type, where you don't have, and they're seeing just by reducing the force of a contraction and the stiffness, can even those patients feel better. And even that data is looking quite promising thus far. So this is what we call as functional class. So you have a graph here, which is the mavacamten about at rest, I mean, at the start of the trial, 14 weeks, 30 weeks, and then this is the placebo. And basically NYHA functional class 1 means you have absolutely no symptoms, and 2 and 3 means you have X amount of symptoms with rest or minimal exertion. And you can see from start of the study to end of the study, more patients went from being symptomatic from NYHA 2 to the lavender color, which is NYHA 1. So meaning they had less symptoms and a lot more compared to the placebo. So that's for the obstructive hypertrophic cardiomyopathy in terms of medications. Now, let's say you're on medications, your pressures have come down X amount, or they haven't come down despite trying all the medications. Then the question is, okay, then what can we do procedurally? And what we do here is, the goal here is this thick heart muscle in the center of the heart, or the septum, is basically preventing blood from getting outside, and you get symptomatic. So it's like, okay, what can we do to reduce that thickness? And there are a couple of options over here. This can be done surgically, and it can be done non-surgically. And usually the surgical approach, referred to as a myectomy, is sort of a more complete approach in terms of getting rid of that muscle and expanding the cavity of the heart muscle. There are a few different reasons that I won't get into today for the sake of time, but basically in terms of figuring out who is a better surgical candidate and who is a better septal ablation candidate. As much as surgery sounds more invasive, and it is more invasive, it is probably the better option in some patients, whereas in some other patients who are not ideal surgical candidates, would probably have better outcomes with a septal ablation approach. So each patient will be thoroughly sort of evaluated, and looking at the anatomy of the arteries going into the septum, because essentially what the proceduralist here does is goes in, injects some alcohol to kill a portion of the heart muscle. And that's a good thing because you want to expand the blood cavity. But here is where a team approach comes into play. When you do that and you cause scar of the heart muscle, there can be more risk for arrhythmias, need for pacemaker. So that's why we have sort of a team discussion when a patient like this comes up, and we decide, okay, this is the approach we want to take. Dr. Gonzalez with the imaging expertise weighs in. Dr. Mohan, myself from the heart failure team weigh in. We get Dr. Olsen from the electrophysiology team to weigh in. And looking at the risk benefit, we sort of lay out a roadmap and say, okay, this is the best procedure from an outcome viewpoint that you should have. Then the other big treatment option is heart transplantation. So we've tried all the medications we can, and either in the obstructive type, we are unable to bring the pressures down, or we bring it down X amount, but not as much as we'd like. In the non-obstructive type, it's not so much a question of bringing the pressures down, but the heart muscle is stiff and the patient just doesn't feel well. So in either case, obstructive, non-obstructive, when the patient says, I have more bad days than good days in a week, I am symptomatic, I don't feel so well, I feel like I'm going to pass out, any one of those symptoms that we can't fix or it's irreversible, then we say, okay, now is the time, I think you're going to need a heart transplant. Now we might do things along the way, like I told you about the treadmill test, the oxygen consumption that we measure yearly, every other year, just to keep tabs and make sure if we see signs that you're trending towards potentially needing a transplant in a year and 5 years, we make you well prepared, you and your family, that it's not thrown as a surprise. Okay, you're doing well, boom, here you go next month. I think we should get you on the heart transplant list. So we want to have that close follow-up and keep you engaged and educated throughout this procedure, throughout this management of this condition. And this is my last slide showing patients with hypertrophic cardiomyopathy have excellent outcomes, almost mirroring patients who undergo heart transplant for other reasons. So it's really good. And especially up until, you can see, so up until 10, 12 years, and depending on the age they transplanted, you don't see any significant difference between the two. And usually patients who end up getting a heart transplant with hypertrophic cardiomyopathy might be a few years older than certain other heart conditions, and that can play into these graphs. But overall, for the most part, patients with HCM have very similar outcomes post-transplant. So it is real good therapy for HCM, just as it is for any other heart muscle condition. So I'm going to stop here and just want to give you sort of a broad overview on how we look at the big picture, how we evaluate CU, lay out a roadmap, and then really, yes, we have all these options in our toolbox, but timing is everything. And to each patient, it is very different when we sort of say, okay, this is the time you should have this procedure done. But that's why we want to develop this relationship with patients and guide them and navigate through this process. Thank you again. Thanks everyone for taking time out this evening.
Thank you so much for that great presentation. Thank you all for your great presentations and the surprise heart surgery. That was unexpected. So we do have a couple of questions and they're a little bit futuristic. So I'm going to ask all of our speakers to give brief answers here because they are future thinking. And the one question is, if you had unlimited funding, what research would you do and why? Obviously focused on hypertrophic cardiomyopathy. So I'll start with Jorge and then we can go through the rest of our faculty. And what's your dream to research in HCM and what do you think you might learn from it?
I would say probably treatments. I would say the most frustrated I am sometimes in terms of what I can offer patients. It's that array of medications. It's basically 3 medications that we have been using for now decades, and when patients, very difficult for patients to tolerate, and when you're on the 3rd medication, blood pressure is like 90/60 with a heart rate of 45, and they're like, okay, how much meds am I gonna? I'm living like miserable. And so the advances now with myocardia and the recent research that was published back during the weekend during ESC, it's promising. It makes me feel like great, like that I will be able to offer something else besides the knife for patients. And I think more medications and more drugs are needed. And hopefully that will be where I will put the money for research besides what we have done.
So your money's on I'll spend money on making new drugs and therapies. So when somebody wins the Mega Millions and they come to me, I'll know what to come to you for. Okay, who wants to go next?
Sure. Yeah, I think that would be nice. What Dr. Olson kind of laid out what puts people at high risk for sudden cardiac death. And often that's after things have already kind of progressed to a certain extent, the, potential LGE, the scarring, but also the family history, that kind of thing. If we had a more powerful tool, whether it's a genetic test or what, but some better way to identify earlier who's at higher risk, not only for sudden cardiac death, but just sort of for progression of disease. Because as much as, there's these phenocopies, there's also multiple phenotypes of HCM too. Some people don't progress into this full-blown obstructive picture or the sort of dilated cardiomyopathy picture who ultimately need transplant. So we had a better idea of how we can kind of prognosticate which way a patient may end up. We may be able to kind of precision treat or give them more precision treatment based on kind of what we know would be the end stage if they continue down that path. I mean, that's a sort of moonshot type thing, but an earlier prognostication would be helpful, I think.
So if I were to turn your words a little bit there, maybe the utilization of artificial intelligence, machine learning, something to data mine either our test results, our clinical records, some biomarker that could help us predict who's going to progress and who's going to have cardiac arrest and who's going to have more arrhythmia and who's going to have more heart failure. That would be wonderful. I'm in with you on that one. Not that I don't want therapeutics, but I would just love to use technology in a new way to come up with better answers. AJ, what do you want to do with all the money that somebody's going to give you?
So I would, this is a tricky one. So I think.
Oh, you muted yourself.
Someone did, okay.
Now you're back.
Okay, so access to care. So I think about, the one, and I think each of us have busy practices and trying to find, there's one reason I think that there are not more programs sort of doing this team approach is because we have, all our incentives in the grander healthcare system are not aligned because of, RVU metrics and all this other stuff. I mean, so I would in some way envision that there are more programs out there that have some sort of a funding support that says, okay, you can, we'll pay you X amount. You do 1 day a month of this clinic, see a whole bunch of patients, don't worry about finances. And for patients too, transportation and things like that, getting them to clinics and getting them seen or a combination of things, sending records, telemedicine. I think telemedicine really allows us to do a lot more. But getting patients to, marrying patients to HCM programs via telemedicine actually would be a great way to get care to more patients.
So I'm kind of liking that idea too. But I guess to answer his question would be to research what methods would better serve larger populations and how we can fund those opportunities.
Yeah, I mean, specifically if we focus on research, I think it would be, I think this focus, with mavacamten on sort of looking at the genes, I think gene editing would be a big area where I think funding could go into really dramatically altering something like hypertrophic cardiomyopathy. Okay, so that's my research answer.
That would be a good one. Nick, do you want to chime in here?
Sure. Real quick, in the short term, I think we need better risk stratification tool. We've historically used surrogates for risk. These things like blood pressure falling or echocardiogram looking at thickness. I think we need to tease out the MRI specifics in assessing fibrosis burden and how that correlates. I think that's going to be a better tool for directly looking for fibrosis. Perhaps teasing out a little bit more whether an invasive type of electrical heart study can be used to risk stratify. So that would be in the short term, better diagnostics to put people on high and low risk categories. And then the way future, I think, is the second question I saw in the Q&A. Wow, gene therapy in the future. We've always had hopes for that in so many avenues in cardiology. I think we have tools to edit the genome, but doing that in a living human is the hardest thing. I think the delivery of that type of therapy is going to be the hardest one. So that, you know, it looks like the question 10 years out, is that going to be a possibility? I think gene editing is going to be a possibility, but I think it's going to be more than 10 years.
Yes, for the participants, I can't see the questions. And I'm not quite sure because of functionality. It's the first time doing it. The other question came after from the same person. What about CRISPR-Cas9 and gene therapy? Do we think that has potential? My own opinion is it has potential for future generations, but if you have HCM, the cat's already out of the bag, and we're going to have to come up with the therapies for those living with HCM, but we might be able to stop our grandchildren from developing HCM, which would be very nice. And I see a name that I know, Tom Callis. I haven't talked to you in a while. So your question to the panelists are, and this is a provocative one. Now, I have to say this with a big asterisk. The mavacamten study is a phase 3 study. It is not an FDA approved drug. So we're talking futuristically here. We're making some hypothesis and thought on this question. This is not an approved drug. We're still figuring it out. But Tom's question is, do the panelists think that mavacamten might eventually be used to prevent the development of disease in at-risk family members? Jorge, I'm going to start with you, or whoever wants to jump in. You think it's a possibility that we can give the drug before hypertrophy occurs to stop hypertrophy from occurring?
It's like, that's a good, I don't think so, but again, it's still research. I mean, I don't, it's kind of like the same question. I got the same question actually recently about the fish oil with the evaporate study in patients with coronary disease. In the ESC came that fish oil was good in those patients who already have coronary disease, and shown that high dose of fish oil of that type of medication will, make the plaque regress. And so the question is like, oh, well, can I take it now when I'm like 30, 40 years old to prevent having coronary disease? I mean, there are provocative ideas, but those are not the intentions of the research, nor the protocol. So it will be a hypothesis that will be very difficult to imagine or answer. I don't know what AJ thinks.
Yeah, I mean, so that's obviously a very interesting question. I think, I mean, fundamentally, mavacamten, it's sort of a myosin sort of inhibitor. So it's sort of like preventing the actin myosin filaments coming together and having that force of contraction. So I think from a hypertrophy viewpoint, preemptively using it in at-risk, I think is a very different question to the question being studied in the Explorer trial. So I would say not for that indication. That would require a whole separate study, because both in the obstructive and the non-obstructive as well. For example, the non-obstructive hypertrophic cardiomyopathy, it's not a thick septum or outflow gradient. None of that's there. But what the drug does, by reducing the filaments coming together, reducing the stiffness, the hope is it's going to show benefit. So I think it's more a contractility issue. And maybe in some cases, clearly it's going to be a spectrum. It's not yes or no. But in some who are heading towards getting more of it, it might be a little earlier indication. So maybe that's how I would look at it.
Anybody else have to weigh in there? I'm going to give a meeting management update in a moment, and we're going to end Facebook in just a few minutes. Anybody else want to chime in on the mavacamten in the preclinical HCM group? I think we all kind of think maybe, but we don't know, and we have a lot to learn. So let's not get the cart in front of the horse. My daughter runs a barn. I use a lot of barn analogies. The horses have left the barn. There, all kinds of barn analogies. Sorry about that. Okay, ladies and gentlemen, look in the chat feature. You will see a Zoom link. Ella is about to leave this meeting and go open a private meeting room. Panelists and participants are welcome to come join us in the meeting. to continue the conversation. If you have any specific questions you would like to ask the panelists or myself or HCMA staff, we're going to go to the meeting room after this webinar closes so that you can openly ask questions. As you know, this is a webinar that has been recorded. It has been live streamed on Facebook. So your questions would have, potentially outed somebody's PHI that we didn't want to do publicly. So the private rooms will not be recorded. The private meeting room that we're putting the link on for now will be open for probably about 15 minutes or so. We'll just take some quick questions. Imagine if we were in a live meeting and you walked up to the speakers at the podium just to say, hey, I have a question for you. That's what we're going to do. And I'm going to call it, let's walk down the hallway and let's meet over in the other room. So I'm going to stay here for just a moment while everybody moves over. Ella, go open the meeting room. Let me know that it's open. Some of our panelists may not be able to join in the other room because they have children annoying them. Needing them right now. So we're just going to try to keep them for a few minutes to answer your questions. This is the first time we're doing this. I'm hoping everything works out okay. So if everybody wants to copy that link and go on over into the other meeting now, attendees should be leaving, panelists should be leaving and going to the link. Jorge, go to the link in the chat room. See the little chat box that said Q&A continue?
I
Open
think.
the little chat bubble.
Okay. Let me see. Let me click.
There, he's gone. Amy, you can go over. Julie, you can go over. And I think